All right. Thank you all for coming on Monday afternoon here at the ASA meeting in San Antonio. My name is Mark Newman. I'm a handling editor for Anesthesiology, the journal of our society, the flagship journal of the ASA. And I'm really so honored and happy to be able to moderate this session that's sponsored by the Anesthesiology Journal on the management of the frail patient. We have four outstanding speakers today. They're all experts and they're wonderful presenters, so I think you're in for a real treat. This is a 90-minute session, so we're going to have the speakers go for about 15 minutes each. And then we'll have the panel come together at the end for questions. This session is being recorded and live streamed, so it's just really critical that if you do have questions in the Q&A, you use the center hall microphone, and just remember, whatever you ask will be preserved forever. We have four presentations today, and I'll give credit to Dr. Bentov, who figured out the proper framing for what this sequence will be. We're going to talk about the now of frailty in surgical practice, which is Frailty Assessment in the Surgical Clinic by Frederick Sieber at Johns Hopkins University. The brain, Frailty in the Brain, Incorporating Perioperative Brain Health into Your Practice for Frail Older Adults by Michelle Humidan at The Ohio State University. The Body, Frailty Biomarkers is Sarcopenia, the answer, and that's by Dr. Bentov at University of Washington. And then Looking to the Future, Practicing Anesthesiology at the Crossroads of Frailty and Delirium. So I'd love to call up Dr. Sieber, if you might be able to lead us off. I'll bring your slides up, and looking forward to hearing what you have to say. Okay. Oh. All right. Thanks, Fred.
Well, thanks for sticking it out here later in the afternoon. So I'm going to talk about frailty assessment and outcome prediction using frailty. And it's important to know that frailty assessment is kind of like the Wild West. There are so many different instruments right now that are available for use. And the intention of this particular talk is not to promote any single frailty assessment. But I want to make you aware that how frailty is assessed determines its classification as to whether or not a patient is frail or not. Now, the Edmonton Frailty Scale and the Fried Frailty Phenotype are the two best studied frailty assessments. And for the purposes of this talk, I'm going to confine my comments to comparisons between these two instruments. All right, so first a little background so you understand what we're talking about. There's two approaches to frailty assessment. First of all, there's the accumulation of deficits, and then there's the phenotype. Now, the accumulation of unrelated deficits, this would be more apropos for the Edmonton Frailty Scale. And the thing to remember about this is that it's not based on an underlying biological etiology. And the deficits that you measure are interchangeable as measurement tools. The other thing is, because of the nature of this deficit accumulation, it's something that's good to use in non-ambulatory populations. The phenotype, on the other hand, is looking at observable traits that encompass physical, biochemical, and behavioral traits. And the things that are of primary importance in the phenotype are energy level, sarcopenia, and nutrition. And comorbidity and disability, which we often think about in frailty, they're related, but they're conceptually different than the Fried phenotype. All right, and this is just to underscore the differences between the two types of assessments. As you can see here with the biologically driven frailty, or the Fried phenotype, there's muscle strength, physical activity. A lot of things are focused on the physical aspects of the patient. Whereas with the Edmonton, which is in the yellow, it encompasses a lot of different things, including nutrition, social vulnerability, and medical conditions. I want to point out two big differences between the two types of assessments. One is that the Fried phenotype does not include comorbidity in terms of the assessment, nor does it include cognition. So keep that in mind later on in the talk. Okay, what about the Edmonton Frailty Scale? What's the purpose of it? And this is the key thing. It's to create a practical multidimensional tool. So it's something that's highly feasible to be done in the clinic. It's also designed so that it can be done by healthcare providers without specific training in geriatrics. It was also developed to assess the limitations of frailty measurements that were focused on a single aspect of frailty, like the physical frailty, or were too time-consuming. And the other thing to remember is that this multi-dimensional approach, they're calling vulnerability or increased vulnerability frailty. And this is just to show you the types of domains that are assessed by the Edmonton Frailty Scale. The important thing to keep in mind is that one aspect of the Edmonton Frailty Scale is that it kind of provides a mini global geriatric assessment so that certain areas of concern in your patients can be addressed. The other thing to keep in mind is there's now a written Edmonton Frailty Scale that you can actually do over the internet and doesn't necessarily require direct interaction with a provider. Okay, the Frail phenotype, things to think about. First of all, this was designed to develop a standardized definition of frailty and to assess its validity, and they're looking at frailty as a distinct clinical syndrome. And the aim was to distinguish frailty from comorbidity and disability, which had previously been used interchangeably to describe frailty. The phenotype is a very strong predictor of adverse health outcomes such as falls, hospitalization, worsening mobility, and death. All right, these are the criterion. And the things to remember about the Fried phenotype is it does require training to perform this assessment, particularly with the grip strength, the manner in which the questions are asked concerning exhaustion, etc., and also the performance of walking speed. And it does require a certain amount of time to do this. In our hands, it's about 20 minutes. All right. All this is great and fine, but what about comparisons between the two assessments? Well, the first thing that you want to know about is feasibility and practicality of these two types of assessments. And the Toronto group led by Dan McIsaac did a really nice summary of this. And you can see here they compared by acceptability and practicality the Fried versus the Edmonton. And you can see here the pluses mean positive and the minuses mean negative. And these were different studies that assessed these particular aspects of practicality and assessment and acceptability. And you can see that the Edmonton really only had one article which gave a negative aspect to its acceptability, whereas the Fried had several articles which said that it was impractical or there was poor acceptance of the assessment. So that's the first thing in comparison of the two is feasibility and acceptance. The second thing to keep in mind is this comorbidity and how that might affect the assessment. And this is from our recent data that I'll talk about this study a little later on in the talk. But what we wanted to do was we took a group of over 500 surgical patients and we assessed them both for the Fried and for the Edmonton Frailty Index. And the other thing that we did was we looked to see in patients that were classified as frail or non-frail what the Charlson Comorbidity Index was between the two. And what you see here is that the Fried frailty, which is the FFP, there's no difference in the comorbidity index whether the patient's frail or non-frail, whereas the Edmonton, which has a certain component of comorbidity in it, has a higher comorbidity index in patients that are frail. And the stronger association between the Charlson Comorbidity Index and the Edmonton Frailty Score as compared to the Freed likely reflects the fact that multi-comorbidity is embedded within the Edmonton construct. All right, how does this affect assessments? It definitely affects categorization of frailty depending on which instrument you use. Now, unfortunately, there's very few studies that give head-to-head comparison of frailty assessments in the same group of surgical patients. So I'll show you what studies I was able to find. So here we see a cardiac surgery study and a thoracic surgery study. And what you see is the same type of pattern, and that's that the Edmonton tends to classify more patients as robust, whereas the Freed tends to classify more patients as either pre-frail or frail. And not only that, but in this cardiac study, they looked at concordance, and they found very, very poor concordance between the two assessment instruments. Here's another example. There's the same type of outcome. This is with TAVR patients, where they're seeing the same type of thing. Higher incidence of frailty in those patients using the Freed phenotype as opposed to the Edmonton, which shows lower incidence of frailty and more robust patients in the Edmonton. Even in medical patients, this same type of outcome is shown. So there are differences in the categorization of frailty depending on which assessment instrument is used. Why is this important? It's important because it will affect your prediction of outcomes, which is why we're doing these frailty indices. First of all, this is from the thoracic surgery study that I quoted, and they were looking at the relationship between frailty scores and postoperative complications. And what they found was the Freed seemed to really predict postoperative complications much better than did the Edmonton frailty scale. Although there weren't any differences, significant differences in terms of prediction between the two and 30-day mortality, the odds ratio seemed to suggest that maybe with greater numbers, the Freed might also be better at predicting mortality. And this is just to show you the receiver operating curve and the area under the curve for the Freed phenotype. It had really pretty much acceptable or moderate discrimination in determining postoperative complications in thoracic surgery. Unfortunately, in this particular paper, they didn't give the area under the curve for the Edmonton frailty scores. Similarly, they looked at length of stay. Once again, same type of thing. They found that the Freed phenotype for point increase in the phenotype, that there was a very, very tight association between length of stay and the Freed and increasing score in the Freed phenotype, which they didn't really see with the Edmonton frailty score. Now, this particular slide kind of highlights really clearly why it's important to keep in mind the bucketing or the categorization of frailty and the assessment instruments. This is from the cardiac surgery study where they looked at mortality over the long term and risk ratios. And the thing is that in that group of patients, they only had 6 patients that they classified as frail by the Edmonton, but 34 by the Freed. And as a result, 3 patients died in that Edmonton group, giving a 50% mortality rate, whereas 11 died of the patients that were classified as frail by the Freed criteria. And that gave a higher risk ratio for mortality with the Edmonton, but a lot of it has to do with the categorization between the two groups. Okay, so this is all fine and well, but you probably ask, what are we doing at Johns Hopkins and what are we thinking about? Okay, this is a process in evolution at our particular institution, and it has to do with a recent study which we just completed. What we did was we looked at over 500 older non-cardiac surgical patients, all who were staying at least one day in the hospital. And we assessed all these patients by both the Edmonton and also by the Frail criteria. And what we found was, once again, similar to these other studies, very low concordance between the Edmonton and the Frail. Once again, same type of pattern. Many more patients were classified as frail with the Frail as opposed to the Edmonton. We did a survey with the surgeons that were involved in this study, and we asked them, what's the most important outcome that you want to know to predict? And they said it's loss of independence. That's what we really want to know, and we want to know how frailty actually predicts that. And what we found, and I'm sorry I'm not showing you the data because it's unpublished, we just finished the study, but I figured it would be interesting for people to know about. Both showed the same increased odds if a patient was classified as frail for loss of independence. But here's the difference. The Edmonton frailty score showed a much higher sensitivity for predicting that, and the negative predictive value. Whereas the Frail frailty criteria showed a much higher specificity and positive predictive value. So given this data, what we're going back to the surgeons about to discuss is we think that the Edmonton frailty scale, going by what we're seeing here, is probably a really good screen initially to try to determine if a patient's at risk for loss of independence, and that for those patients that are classified as frail, maybe we can get additional information by using the Frail criterion then later on. So that's the approach that we're going to propose to take in the future at our institution. So the take-home points for this particular talk are the focus of the Edmonton and the Frail assessments differ in their conceptualization and the measurements that are being used. And the stronger association between comorbidity and the Edmonton compared to the Frail likely reflects the fact that multimorbidity is embedded within the Edmonton construct. And the low concordance between the two instruments may lead to differences in outcome prediction. So if you're thinking about choice of frailty assessments, it depends on the feasibility, which I discussed between the two instruments, and also the purpose of the frailty screening. And in our case, we'd like to focus on loss of independence. And with that, I just want to put in an advertisement for NIDIS, which if any of you are interested in working in the delirium area, I'd suggest going onto this website. There's a lot of really good resources and all sorts of programs and webinars and all sorts of things if you're interested. Thank you very much for your attention.
All right, thank you so much. Next, we'll have Michelle Humadin come up and speak on looking at frailty and brain health.
All right. Well, welcome, everybody. Like Mark said, I'm going to be talking to you about some practical considerations that you can take into account when you're caring for a frail patient or any patient, really, that's at risk for cognitive dysfunction after surgery, but a particular focus on frailty. So there is a relationship between preoperative frailty and postoperative delirium, which is a very serious complication and very common complication after surgery that everyone's aware of. And the reason that this is important to distinguish is because if delirium sets in, the patient's risk of having a lot of other bad things happen goes up significantly. So the risk of going somewhere other than home, the risk of other complications, even the risk of death is significantly increased if they have postoperative delirium. And so this study here shows that a meta-analysis looking at this relationship between frailty and delirium, and you can see that there is a significant relationship there. Now, when I was preparing for this, I was kind of thinking about the fact that physical frailty is usually where my mind goes when I think about frailty. But there's also a concept of cognitive frailty. And our colleagues in the neuropsychological world and neurology world, they have placed some definitions around these concepts of physical frailty and cognitive frailty and the overlap that they have. And the reason that they've done this, in my understanding, is to give us some perspective at which points of these overlaps can we have the potential to maybe reverse pathology, to reverse the trajectory that the patient's on, and ultimately have them present for surgery in a better state and have a better recovery afterwards. And so what you'll see on the top there are kind of the two categories of physical frailty, and on the left there are the two categories of cognitive-based deficits. And so in theory, if you have a patient that's got some existing mild cognitive impairment at baseline, which by the way, about 1 in 4 to 1 in 5 of our patients are probably showing up with some degree of impairment that are older patients for surgery. If they just have that aspect and not the physical piece, we're in the realm of maybe being able to really do some things to modify their risk after surgery. But you can see if they have cognitive risk or deficits at baseline and physical frailty, they're in this category of cognitive frailty that really puts them at a significantly increased risk. Out in the community, there's somewhere around 1 to 5% or so of patients walking around, or community dwelling adults walking around like this. And then when they come in our setting where we're taking care of them, that increases significantly. So we need to be aware of the fact that frailty is not just a physical piece of how we evaluate patients or characterize them, but there's also cognitive components to that as well. So I wanted to bring up the framework of the age-friendly health system. And the reason that I wanted to bring this up is because if you're like me, I've been trying to build momentum around frailty and preoperative assessment of frailty and cognition in our older surgical patients. And it's a struggle sometimes. It's hard to get buy-in and resources for these things, even though it's best practice in our guidelines and our recommendations. And we are well aware of the fact that identifying these patients is important because of their risk after surgery. So the age-friendly health system now is bringing some much needed attention and momentum to my cause at Ohio State. And if you're not familiar with it, there's 4 M's, 4 categories of what we really need to take into consideration for our older patients, which is what matters to them, the medications that they're on, their mentation, and their mobility. So CMS has put forth a new framework to help guide our management of older surgical patients. And this is specifically focused on inpatients for right now. But I wanted to make you aware of this if you're not already, because this has brought a huge amount of resources and emphasis at Ohio State to our mission to have better identification of these high-risk patients before surgery. So right now, this came out in January. And the measurement period is going to be this calendar year. And for right now, there are 5 domains, and it's a simple yes or no. You're not judged on whether or not you're doing these things well, or, it's just a simple reporting and a simple way to get people aligned on where we need to move toward. And then eventually, I think there'll be other types of things tied to this. But it is going to be reported in Care Compare, and this is optional. But you can imagine that there will be implications for health systems that participate in this and do it very well. These are the 5 domains that you can see as part of this initiative. And I want to highlight the frailty screening and intervention piece. So there is no shortage of information out there now to help guide us about things that we should be doing for brain health in the perioperative space. There are a lot of best practices and expert consensus and guidelines to help guide us. These aren't specifically focused on frail patients, but they are focused on high-risk patients from an aging standpoint that have risk for cognitive issues after surgery. So they are focused on promoting brain health. If you look at all of these, there are some common themes that come out from these. One is that preoperative risk assessment is critical. This allows us to identify the high-risk patients. It improves our team communication about these patients and really puts them on our radar so that we can keep track of them and prepare them and make sure that they have a successful recovery. The preoperative screening, I think, is important too, because if you're thinking about how to care for these patients, there's two buckets of where you might find yourself. There's the bucket where you're removed from surgery and you have more time to do things, but there's also the bucket where you're meeting them on the day of surgery. And even if that is the case, doing a quick screen of some sort to get the patient's baseline cognitive status, put that in the medical record and communicate that to the care team can be of benefit, because it can relay that they're at risk, and different things can be put into place intraoperatively and postoperatively to help them avoid delirium or poor cognitive recovery. Another theme is that the patient and the family need to be counseled on their risk. So when they have pre-existing cognitive deficits or frailty at baseline, like I said, they have a very significantly increased risk for other problems after surgery, and that really should be part of the conversation and part of what we try to mitigate if possible. There's also no clear superior choice for an anesthetic at this point. However, we should be prioritizing intraoperative hemodynamic and physiologic stability, and also focusing on our medications that we're giving to patients. And then lastly, a common theme that I identified is that patients need to remain involved after their surgery. And so they need to be involved in their environment and in their care. So we can't let them be detached without their hearing aids, without their glasses and things. They need to be engaged in their environment and engaged in their care for a successful brain recovery. So I want to spend a couple of minutes giving you some options for screening tests for cognition specifically. This review, or this best practice guideline by Berger and colleagues, is a few years old now, but it has a really nice table in it that has some brief cognitive screening tools that you can consider using for your patients. And the mini-cog in particular is one you'll see a lot in the literature, and it's also one that's been shown to be incredibly consistent, whether it's done weeks in advance in a clinic setting or on the morning of surgery in the preoperative holding area. Other ones you'll see listed here, also very good options, and it gives you some sense of how long it would take to administer these. A more recent update has come from the Spocky group, and they also list the mini-cog and several other options. What's great about this review is it provides a very tailored overview of how these are used in the perioperative setting. So if you're picking a screener for cognition, you want to make sure that you're looking at something that's actually been tested and used in preoperative settings, as opposed to just community settings or in primary care settings. You also want to take into account the patient characteristics, like their language, their culture, their education level when you're picking a test. Not everything works for every patient. Things that are very language-based might be challenging in certain situations, and you might want to do something more like a clock drawing test. Ideally, we should be co-assessing other things like their instrumental and activities of daily living to have a more clear picture of how their trajectory is going to be. And then screens need to be documented in the EMR and communicated with the care team. This is really important because it allows us to have these goals of care discussions. That's part of the 4M's framework. It allows us to have a transparent discussion about risk, and then again to prompt the implementation of delirium prevention bundles after surgery. So if you haven't adopted this, you're in good company. A study by one of our other panelists, Dr. Diner, showed that this is really not done universally, frailty screening or cognitive screening, at least according to survey results from anesthesiologists. But I want you to feel empowered to start working toward this. And this webinar collection that's on the Brain Health Initiative website, lots of folks on this panel are represented there. They have wonderful resources that are very much worth your time to check out. In particular, number one, the practical tips for preoperative screening is definitely worth your time. It allows you to not be intimidated by this. It focuses on what you should be doing. It actually gives you an example of how to engage a patient with the mini-cog. And really, the important thing you want to do is practice, but also emphasize to the patients that this is just a vital sign, just like their blood pressure, just like their weight, or any other thing that we would collect. It's a starting point so that we can have better discussions, better risk understanding, and then also set them up for a better recovery, hopefully. Their surgery won't be canceled. I think a lot of patients are really worried about that. That's not necessarily what needs to happen. It can be just a screenshot if we don't have much time. It can be something that we can intervene on if there's more time. I do want to highlight that our surgeon colleagues are totally on board with this, or they should be. Their society is, and they put out a lot of resources that focus on this. Being aware of what the patient's baseline cognitive status is will help us adapt our communication. It allows us to engage their family, have these really intentional discussions about their goals of care and risk, like I said, and sets us up to have a more collaborative team approach to their care. So here are a couple resources I wanted to share with the group. This infographic I really like. It's available on the Brain Health Initiative website. It has a listing of things here that we can go and tell our patients that they can practically do to improve their recovery after surgery from a delirium standpoint. So right at the top there, you'll see stimulating the mind. That's actually what when I have my research hat on, that's what I study. But in addition to that, you'll see simple things for just general good health, like moving, getting good sleep, being engaged with your environment using your aids, staying hydrated, and having good nutrition. The APSF is also putting a lot of energy into creating resources for providers and patients about these types of topics. And so I encourage you to check out their website and stay tuned because I think it's going to continue to evolve. So the Brain Health Initiative has another infographic that I like to share. And again, it emphasizes some of these practical things that we can encourage our patients to do to protect their cognition. And it's things, again, like having their sensory aids, getting good sleep, doing things to stimulate their mind, like engaging in challenging crosswords or computer games. Social interaction is very important, is becoming something that we are paying more and more attention to. Their medications, being active. So these are just really practical things that we can do to help our patient feel more empowered to mitigate their risk if there's time. This is another infographic that's targeted toward families, which I like to share. And it has some practical things that the family can look for, what to do, when to reach out. And this is an important piece of engaging the families and having them help take care of the patients alongside us. So I just want to say one thing about, or a couple things about prehab. So prehab is incredibly heterogeneous in the literature. And when they look at it specifically in frail patients, there's definitely, as I said before, an association between frailty and postoperative outcomes being poor. But there's not a lot of evidence that we're able to reverse this risk at this point based on prehab, specifically in frail patients. But the evidence is growing that we're kind of on the right trajectory. So things like exercise, nutritional support, and patient education are steps in the right direction that might be mitigating this risk. What you won't see listed there, which is missing from a lot of the prehabilitation literature, is a specific emphasis on brain health, brain prehabilitation. And that can take many forms. That can be things like coping with stress, anxiety reduction techniques, breathing techniques, but also stimulating brain activities like I mentioned before. We still need a lot of work in this area. So a few things about the intraoperative management that you can practically take away from these guidelines. I have up here the two most recent that have come out, one from the Europeans and one from the ASA. And they both align on the fact that patients, there's really not a specific type of anesthetic that's clearly favorable for brain health. So neuraxial versus general equivalent, and TIVA versus an inhalational anesthetic equivalent. So whatever you think is best, can taking all the factors into account for a patient from a brain health standpoint is adequate. This is a pathway that you can find on the Brain Health Initiative. It's from UCSF, and it has some practical things listed there that you can take into account in your intraoperative management. The guidelines are really clear that a MAC adjusted for age is one of the primary things that we can do for brain health in the operating room. And also there's no routine prophylaxis that's recommended, but you can consider dexmedetomidine from our ASA guideline that just came out that I showed. But other general themes are things like paying attention to the different physiology that older patients or frail patients present to the OR with, and other things that we need to do with our medications, keeping them warm, taking into account that they have friable skin. Those types of things can help them do better in the operating room and protect their recovery. Also, you should be trying to spare them opiates or other medications that can affect their delirium incidence. And even though Neuraxiol is not necessarily a better anesthetic, if it's contributing to a better pain plan, it should be considered, along with regional. I will just say one word about EEG. The Europeans in their guideline, they have kind of gone all in on EEG, and they think that anesthesiologists should be working toward being trained in this and utilizing it in their practice. The ASA guideline really feels like that the evidence is not there yet to say that, but I think this is going to be an area that continues to evolve, and it makes sense. It's the one organ that we don't monitor very well around surgery, and it's the end organ of all of our drugs. So I think that this will be something that evolves. If you're skilled with this, great. If you're not, you should consider finding ways to be educated, of which there are many. And it's not that difficult. It just takes practice. There are some definite guidance on medications that we should avoid. So things that are antihistamines, long-acting benzodiazepines, meperidine, and metoclopramide, anticholinergics, and then other psychoactive medications are all kind of called out as things that we should be very cautious when we use in older patients and in frail patients. There's been some recent literature come out about midazolam in particular, and the APSF has put out a statement that says that, again, long-acting benzodiazepines and drugs with central anticholinergic actions should really be avoided in older patients, but things like midazolam that are short-acting should be used cautiously. It's not an absolute no at this point, but it's something that you should think very critically about if it's absolutely necessary. A risk-benefit is warranted in older and frail patients. I do want to say one piece about hypotension. I think intraoperative stability is really important, and it's something that we're not capturing very well. The APSF has put out a call to action about hypotension in particular. So this is going to be something that we continue to pay more and more attention to and use data to help guide our practices. When patients have even brief periods of hypotension, their risk of major adverse cardiac events and acute kidney injury goes up significantly. Post-operatively, delirium prevention bundles that are based on the HELP system, the HELP Elder Life program, or some modification of that are very successful in helping promote good brain recovery after surgery. And they kind of go back to that 4Ms framework. They have different protocols as part of that study that I just showed that they use to help patients recover, and they're very focused. It's kind of tailored on what the patient needs. So some of the universal ones include an orientation protocol to make sure, again, patients are engaged with their environment, they know what day it is, where they're at. Also, cognitive stimulating activities and interactions with staff and family, and then early mobilization protocols. Those are things that should be generally done for everyone. But then there's more tailored protocols depending on the situation that can also be implemented, things focused on pain, sleep, nutrition, fluids, and so on. So we have a lot of good work that can be done in the post-operative space, but still preoperatively and intraoperatively remain important times to be aware of brain health as well. So that's everything that I wanted to share today. I will say I didn't talk about my research at all in this lecture, but if you want to follow it, this trial here is doing brain exercise, sleep hygiene, and then some opiate-sparing pain control in older patients presenting for cardiac surgery. So that'll be coming soon. And then I love the Rolling Stones, and if you want to watch some successful aging, I think they're a pretty good example of it. So thank you very much.
Next up is Dr. Bentov from University of Washington in Seattle.
All right. Thank you. And my name is Itai. Thank you, Mark. And I will be, it's coming up. Okay, perfect. I'll be talking to you about a frailty biomarker that I think we should explore specifically as an anesthesiologist, namely sarcopenia. This is not moving. Nope. All right. Some of the results that I will be showing you have been generated from research that was supported by several things, but no real financial disclosure. So frailty is a multidimensional entity. it includes multiple physiologic systems. So when I try to reduce it to sarcopenia, you see that I'm not really trying to reduce it to sarcopenia, but I'll move into that. The point about frailty is that it causes vulnerability to adverse outcomes, and it's pretty easy to see which one I think is frail and which one is not. Mark and Stacy have already taught us that anesthesiologists do not assess frailty. This is 5 years ago, but they rarely or never assess frailty, and these are the respondents of the survey. So this was followed by creating a frailty toolkit, the Brain Health Initiative videos, all these educational things. This is all good and well, but apparently, even with everything going on right now, we're maybe at most at 40% frailty assessment by anesthesiologists, even despite the fact that we're recommending it in the older advisory adult, frailty and cognitive assessment. So what's going on? Why with all these tools? It's not a knowledge problem. There are many tools to assess frailty. They take long, they take short, they need this, they need that. All of them are there. And in this list, we've listed just a few. There are literally tens of frailty tools that are not that complicated to implement into our study. I guess the problem is that we don't have a good biomarker. We like simple things. We like to have a BNP. I can do an echo, but I really like to send a BNP. Is this heart failure? Is this not heart failure? And I can go from there. So why don't we have something that is simple that we can just switch on? So let's look at what we usually take. And there's a long list of here. I just am trying to make a point that we're looking at it. But none of these long lists, whether it's albumin or hemoglobin or vitamin deficiencies or all of these wonderful things, is good enough to discern between frail patients and non-frail. Yes, there is an association, but this is not good enough to be a biomarker. I'm a molecular biologist by training, and I love looking at things. I even have my favorite molecule. This is what actually got me looking at frailty. I love IGF-1. Talk to me all day about IGF-1. And during aging, during the process of frailty, there are all these neuroscience is teaching us there are all these biological processes. And underlying frailty are distinct biological processes that we can identify. Some of them are inflammation and oxidative stress and cellular senescence are the main ones. And we have ways of looking at these processes in a molecular biology way. IL-6, TNF-alpha, indicators of oxidative damage, again, my favorite IGF-1, but again, not good enough. This gives some associations, but this is not good enough to act as a biological marker. Here comes sarcopenia. So let's talk a little bit about sarcopenia. Sarcopenia is a loss of muscle mass and function, per definition. Okay, so there's a loss of muscle mass, there's a loss of muscle function. We know that during normal aging, it will happen. We can mitigate some of these effects, but there will be loss of muscle mass and function during aging. In addition to that, we know what are the molecular mechanisms that lead to this. So this could potentially be a target for the future. I've put in one that has steroids. We all know that patients who receive steroids, receive high-dose steroids, we see them as losing muscle mass and function. And again, I put in IGF-1, you can't escape it. So let's go into a paradigm, okay? Aging has all these biological processes. Specifically, I'm talking about senescence, inflammation, and oxidative stress. They cause chronic disease, they cause frailty, and they cause sarcopenia. And sarcopenia basically puts you in this vicious cycle. You lose strength, you lose activity, the metabolic rate is reduced, you lose weight, you consume less nutrients and less calories, you become cachectic, which is a vicious cycle that just propagates itself. And ultimately, when an acute stress event happens, like surgery or injury, we are going to see more adverse outcomes. Not only is it a marker, but again, it could be a target for intervention. Because if we talk so much about prehabilitation, look at how much of, this is Franco Carli's from anesthesiology, the diagram that I really, it encompasses so many things. It encompasses the brain, but it encompasses so many things that are imperative for muscle maintenance, muscle strength maintenance, muscle mass maintenance, nutrition, etc. In fact, when you look at Linda Fried's original frailty phenotype description, two of those things are classical: loss of muscle mass and function. There's a reduction in gait speed, and there's a reduction in grip strength. I put in a small study over here that look at esophagectomy. So people who just came in and did a grip strength measure. Okay, so you give them dynamometer, and they just give, and you can see that on the x-axis you've got the grip strength, and on the y-axis the percent of complications and mortality for each of the grip strength. So just by having a small, a simple measure of strength, we can get all this information. I want to show you another example of something that uses muscle function. This is Tom Robinson's study from Colorado. So what he did was a time to get up and go. So this is a very simple test. You sit down, you start the clock, you get up, walk 10 feet, turn around, go back, sit down again. Stop clock. Really simple, right? So he took cardiac patients and he took patients for colorectal. I want to highlight the patient for colorectal because the effect size is amazing to me. So the rate of, and the definition is fast is less than 10 seconds, slow is more than 15 seconds. It's a very simple definition, right? In those who were fast, the rate of complication and mortality were 13 and 3%. In those who were slow, the rate of complication and mortality was 77 and 31. Simple, quick, informative, not so fast. I love dynamometers. They are expensive as hell and they disappear. I love walking tests. I tried to buy the ones from Amazon for $25. They don't work. It's not, you need a real dynamometer to get good results. They're about $700 a piece, and they disappear. This is the person on the bottom of it is in charge of our pre-anesthesia clinic. So I go to her and I say, you need to tell your nurses to, and she looks at me and she says, you need to ask your nurses. And because I'm married to her, I realize that things are not as simple as I want them to be. So I need something else to help me. So I'm moving from sarcopenic function to some sarcopenic mass. And we actually have a way of assessing sarcopenic mass. Almost all of our patients before major surgeries get some type of radiology. This is a simple way to map out all the muscles. And people, before we even looked at this, started looking at these and said, people who have low muscle mass, I'm sorry, I'm going into every time that I'm turning my head. People who have low muscle mass will do worse after surgery. The problem with this is that in order to do that, you need specific software that will chart out and calculate all the muscle mass. And we need something simpler. Well, there is something simpler. You can look at a single muscle, the psoas. The psoas is easy to identify. It's a main flexor of the hip. It's very easy to delineate. And I want to show you a study that looked at orthopedic, that looked at psoas sarcopenia in orthopedic patients and look at postoperative mortality. And in those who are who have psoas sarcopenia, there is almost a 50% increase in mortality after surgery. Now, I told you that frailty is a multidimensional thing. So if we're looking at a slice, we can look at other things. So the same way that we're looking at the sarcopenia, maybe we can add another measure, i.e. osteopenia. And this is very simple. It is so simple that it can be done by a first-year medical student. It is so simple that it was indeed done by a first-year medical student. So what we did over here was we took a cohort of patients that went through our institution, went to the ICU, and had on their admission abdominal CTs. And we divided these cohorts into 4 groups. Those who had sarcopenia, those who had osteopenia, those who had both, and those who had neither. And this is the Kaplan-Meier curve that you can see at 1 year, and you can see that if you had neither sarcopenia and osteopenia, you were doing well. If you had one of them, you would do slightly worse, and if you had both of them, you would do more significantly worse. Well, most of our older patients do not get necessarily just abdominal CTs, but any patient, when we look at the guidelines for the radiographs, if you fall and you're older than 60, even if you didn't lose your conscience, if you have a significant fall, you need to get a head CT. That's what we teach the ED physicians. So we could look at head CTs. Again, multidimensional. We look at this point at masseter muscle, and we look at the bicaudate ratio. So basically the idea is that as our brain atrophies, the ventricles become larger, and we can look at the size of the ventricle and the size of how much the brain has atrophied. Again, first-year medical student. And what you can see is if both of them are normal, if one of them is abnormal, and if they're both normal. So in a very simple measure, we can incorporate numerous things and actually get that information. But anesthesiologists don't just look at CTs. We do ultrasound, right? We do them for echoes and nerve blocks and putting in IVs. We are very facile with ultrasound. So why don't we look at sarcopenic ultrasound? And Cici Canales from UCLA has done just that. So she took and found that there is an association between the rectus femoris. So you put an ultrasound on the rectus femoris and measure you can see the femur really well over there, and you can measure the size of that. And she also did the same thing with psoas sarcopenia and showed similar results. So where are we taking this? We can do CT, we can do ultrasound. The information now can be radiographic information can be incorporated into the medical record. It is done almost automatically in most of the medical records. We can calculate that and get that information very quickly. So I think that everybody's talking about AI, so I've got an AI. This is not AI generated. This is talking about we should be able to use sarcopenic data into frailty data that we collect, as well as other seromarkers. There is an amazing, how many of us are carrying a phone or an activity, and how many of us can walk around and we can get all this data to learn about mobility, to learn about sarcopenia, and people like Dan Rubin, Kim Rango in Vanderbilt in New York are doing that, and more people are. I think the information is available, and we should be able to collect and see that information before surgery. And lastly, even in ultrasound, on the picture over there, what you can see is a healthy young adult. You can see the striation of muscle very, very clear. And for older adults, and as they become frailer, you can see that striation that we're so familiar when we are doing nerve blocks becomes murkier and murkier, and the tissues become this. So I think there's an opportunity for us to continue the research and to contribute significantly to that. so at the end of this session, I was supposed to run to my plane, and this is why I left you this. If anybody is interested in question, but my flight is 3 hours delayed. So if anybody wants to talk about anything, please come up and we can think how we can do more things together. Thank you.
Thank you, Itai. And last but certainly not least is Stacy Diner, who will help us put it all together and look towards the future.
There you go.
Thank you, Mark, and thanks, Itai. I'm sorry about your flight. It'll be my turn tomorrow. So today I'm going to talk a little bit about the future as it pertains to our understanding of the overlap between frailty and delirium. And I'm not going to talk about the future like the time when there's spaceships, but hopefully things that just build on the concepts we've talked about today and the things that hopefully we'll know more about in what I believe could be the next 2 or 3 years. So I do have some disclosures. I'm Vice President of the American Board of Anesthesiology. These are my own views today and not necessarily the board. I've served as an expert witness, and I have consulted for Medtronic. So frailty and delirium have a lot in common when it comes to risk factors. Some of them are well known to you, like age. Low education is an interesting one. I think as anesthesiologists, we're just becoming more aware of the importance of social determinants of health and the outcomes of our patients. But also, as Michelle mentioned, depression is a big deal for older patients after surgery. The persistence of pain and things that we've only started to dip our toe in as anesthesiologists, like the problems with nutrition. We're more familiar with the two things on the left, like chronic disease and medications and polypharmacy. But to really treat the whole patient and perhaps get a hold on what's going on with frailty, we may need to think of ourselves as perioperative medicine doctors and start to dip into some of these more comprehensive factors. I think when I first started in this field, we talked about anesthesia and neurotoxicity, thinking that it was the drugs we gave people in the operating room that were doing something really terrible to their brain. But it turns out that what you've done to your body over like the course of your lifetime is probably more important than the 40 minutes we have you or the 2.5 hours we have you under the table, closely controlling your physiology with drugs that have had to go through a pretty rigorous FDA process as compared to whatever you took at the Rolling Stone show in in the 60s. Not saying that about Michelle at all. So we know that frailty and delirium are expensive, and I think people are always afraid to take home the idea of doing frailty and cognitive testing, even the simple things that Michelle showed you, because they feel like they can't tell their C-suite, like, I need money, time, and a driver for this. But honestly, we know that patients stay longer in the hospital if they're frail or they're delirious. I'll show you a little slide about this. We're starting to understand that frailty and delirium may cause elevated costs at different time points. So you can see that 30-day costs are pretty different with people who have delirium and don't. However, if you look at the 1-year cost for people who have had a total arthroplasty between patients who are robust and frail, so top is robust and bottom is frail, the green part is the time of surgery, and the gray part right next to it is 30-day readmission. And you can see that costs are fairly similar, maybe a little bit more for frail patients through 30 days. But where you get this giant increase in cost for these total arthroplasty patients is in the year that follows. But this is cost, so it's almost double the cost to do surgery for these total arthroplasty patients if they're frail. Now, why is this going to be important to your hospital? Michelle was talking about the frailty measure that's coming up, but some of you who practice in the United States may be hospitals that are doing these team bundled payments. They're called transforming episode accountability models, and it's going to be mandatory in 741 hospitals January 1st, 2026. Does anybody know if they're in a hospital that's going to be doing teams bundled payments? I know I am. I see a hand out there. There are 5 major procedure categories. These include CABG, lower extremity total joint, spine fusion, major bowel, and hip fracture. And they're defining episode of care as admission up to 30 days after discharge. And hospitals are at risk of losing serious money based on whether the care episode, so all the way from pre-op through 30 days, exceeds benchmark costs. And, spoiler alert, they're going to be looking pretty hard at preoperative evaluation to think about how we can identify people who may have these problems proactively and help them so that they don't cost more money in that pre-op to 30-day period. We're all going to be asked to be part of that. I think it's already been stated that frailty is associated with a higher risk of delirium. Actually, this paper was done, I think it was Fritz's, a medical student of Fritz's who did this as a summer project. But, although Fritz talked about that there are all these different tests across studies, these studies all use different measures, the incidence is usually about twice as frail. And so we wrote a review, which I believe came out this past year, 2024, about a unifying framework for the interplay between frailty and delirium. And the truth is they're probably a vicious cycle. And when you're faced with an acute stressor and you're not so frail, you're likely to recover quickly, and delirium's unlikely. However, if you're more frail and you have an acute stressor, it's going to take a lot longer for you to have a functional recovery, and you're more likely to become delirious. And so we really think that the relationship between frailty and delirium may be bidirectional. But it may even be a little bit more subtle than this. So this is a study that you can't do in living humans, which is to actually open up people's brains and look at their neuropathology. And so what I'm showing you here on the top is frailty index, and on the far left-hand side are low frailty. On the right is higher frailty. And then this x-axis over here, this y-axis is neuropathologic burden. And so you can see in people who have a medium neuropathologic burden when they open their brains after they're dead, you can see that people who are not so frail, about 30% of them were judged to be demented. But people with the same neuropathologic burden, same thing going on in their brain, 74% of them were judged to be demented. And so, what's that about? So does presence of frailty actually change how the neuropathology is expressed? Or does frailty pathology actually accelerate the progression to dementia? And these are the things we don't totally understand quite yet, but they're probably at the core of how to help these people not get worse and worse. I think what we all hear from our patients are patients who are never the same after anesthesia and surgery. And those very frail patients are at very high risk for going on that downward spiral. So how could what I'm telling you change patient care? So if delirium worsens frailty, then the answer is to prevent delirium. We've all talked about protocols to improve the environment, minimize harmful medications, and optimize pain control. But Ju et al., and this is Liz Whitlock's group, published in JAGS, Journal of Geriatric Geriatrics, that there are delirium phenotypes. So perhaps we're not all delirious just in one way. So depending on the type of surgery you have, depends on the cluster of risk factors you have that predispose you to becoming delirious. So for example, spine surgery patients are more likely to have a pain phenotype risk factors. So a lot of their pain a lot of their delirium is associated with poor pain control. So in spine patients, the key to making sure they don't become delirious may to be aggressively figure out how to control their pain. Vascular and general surgery also have phenotypes that are distinct and may have different treatments. So we haven't yet parsed out these surgery-specific treatments to prevent delirium, but I believe that that's the next step. We do know that delirium prevention bundles can pretty effectively prevent delirium, and it always disappoints anesthesiologists when we say, well, there isn't a magic bullet we can give during the intraoperative period, but that doesn't mean that you are divorced from this patient becoming delirious or not. You can still be a very important part of identifying these high-risk patients and then working with the larger care team to make sure they get the support they need so they don't fall off a cliff after surgery. Also, there's good data to suggest that patients who go on to have delirium, many of them have problems in the recovery room. So there are examples of trials to reduce frailty on this slide over here. Physical activity has the most and best evidence for it. The rest are still a bit hazy, but it's an evolving field. Prehabilitation studies have been relatively disappointing. Dan McIsaacs, who's done a great job and is a frailty warrior for sure, a Canadian ICU doctor who's also an anesthesiologist, did a study looking at home-based prehab to improve postoperative recovery, and he really found no difference. However, the problem may have lied in the fact that program adherence wasn't great, as evidenced by the fact that patients' walk tests didn't get better when they were prehabbed. But perhaps prehab doesn't address all or enough of the reasons for frailty or the parts of frailty that cause the outcomes of interest. And so this is a study that came out just this year looking at directed prehab with recreational moderate to vigorous physical activity, and they were actually able to show a separation between groups where patients actually got stronger in terms of their METS ability and their predicted maximum volume of oxygen consumption. And when you're actually able to get a group to be better and stronger, and this isn't surgery per se, this is disease recurrence in cancer patients, they were actually able to show if you prehab patients, you could decrease the recurrence of cancer. So don't throw the baby out with the bathwater when it comes to prehab. We may need more specified endpoints to do a good job. And what I was hoping that Itai would say, although he didn't say it, so now I get to say it, is that frailty is probably not just about loss of muscle mass. It's about multiple different dysregulated pathways. So angiogenesis is one of them, metabolism, messed up metabolism, and insulin sensitivity is another. Cell senescence, whether cells know to die at the correct time, is another one. And there's actually evidence now with proteomic studies that look across like all human proteins and then group them into categories that you can actually predict in midlife before anybody has any sign of frailty who's going to go on to become frail. And so our bodies actually start to change and go down these frailty paths much earlier than we ever understood before. And as we start to get a better knowledge of why people are frail, it's possible that there may be subtypes of frailty. Maybe some people have metabolic type frailty and other people have sarcopenic type frailty. And so treating these patients and helping them not to get sicker, first of all, probably will take a very wide approach, and I hope anesthesiologists will be on board with this change because, again, if we want to think about how we add specific value to a care model, it may not be just by sitting in the operating room and giving drugs. It may be using the totality of our skills as physicians to help patients. So in summary, certainly the overlap between frailty and delirium is well described. However, the pathophysiology is not well defined, but there's evidence for preoperative prediction as Fritz told us, and there's some evidence for prevention. We need more studies out there that include both frailty and delirium. And now people are starting to make sure that studies in older adults measure both. But the studies before, say, 5 years ago often focused on one or the other and not both, especially in surgical populations. And hence, that's a real limitation in our literature. So in the future, I hope we can identify which pathways are in common between frailty and delirium. I believe there probably are subgroups of patients that benefit from tailored treatment. And I think prehab will be only one example of things we'll be able to do to prevent decline in these older adults. Thanks so much.
Thanks so much, Stacy. That was just such a great panel. Let's just have another round of applause for all our panelists. I'd like to invite all our panelists to come up, and we have time for a Q&A. Jim Rathmel, the mic is yours.
So first, on behalf of the journal, I want to thank all of you for contributing to the panel. It was phenomenal, really phenomenal. The question I have for you is, so you've kind of laid out the territory. We know what works, how to measure things, what doesn't work, and we have shown that it's important. Frailty is incredibly important. Is there a point at which we'll get to the point where people just shouldn't go forward? So we assess this in a meaningful way, and we say the risk-benefit ratio for this patient is strongly against moving forward with surgery or any other intervention.
I wish I had the slide here, Jim, but I have a slide about outcomes for frail older adults. And the truth is, if you're having a total joint arthroplasty, being immobile for older adults is a death sentence, like far, far and away. So I don't know that it's always about that you shouldn't have the surgery, but it is a risk-benefit discussion, and it may be specific for the surgical procedure and the patient and their stated goals.
So I think it's that was actually the first question that I asked myself about frailty. Should we, is there a difference for patients who are coming in for pain-related surgeries? So they're coming into surgery because of pain. The first question that I ask myself is, does frailty actually reduce their pain? And even that is not obvious. So
interesting.
But there is some evidence that frailty actually can reverse if you reverse the condition that likely predispose them to be frail. So it's not, frailty is not that you're always frail. You see it best in transplant patients. A lot of liver and kidney transplant patients are frail prior to surgery and then vastly improve post-surgery.
Kidney transplant is a classical example of something that can reverse frailty. Yeah.
I'll just offer, some of these findings, which, the Tom Robinson's finding on the Get Up and Go test, that 33% of people had complications after colorectal surgery if they can't do the time Get Up and Go test within 15 seconds. I think there's a whole other dimension of it, which is that this is key information to share with patients, whether or not we're acting in a gatekeeping fashion to make this part of our prognosis that we offer for them to help them make decisions about what they want to prepare for. I think that's absolutely critical, and we could do so much more there.
So just kind of getting into my second decade of practice, I feel like the pendulum has gone to one side where we are so equipped to take care of very sick, very complicated, put people through surgeries that, are very invasive. But I'm hoping that the pendulum will come back a little because of this awareness that, the cost, the outcomes, and all of that are just, not ideal, and maybe is the way to put it. And I'm hoping with the CMS measures and the different things that patients will become much more aware of their risk and will kind of put pressure on us to be very intentional about the goals of care discussions and have these very transparent engagement with them and their families about what the real risk is and what their potential to have a benefit from a particular surgery actually is versus their potential to have bad things happen. So.
Yeah. National requirement for a goals of care statement for everybody in the United States before they hit the emergency department, right? Right.
I can't answer your question directly, but I think something that's really important is that anesthesia and surgery is on the same page in making these decisions. I don't know about your experience, but I haven't oftentimes found that to be the case. So I think that one of the things that behooves us as anesthesiologists is to work with our surgical and geriatric and internist colleagues to make sure that we're giving the same message about the outcomes of the surgery.
Yeah, I totally agree. I didn't mean to put us in a gatekeeper fashion, but just would this information lead to a decision against these things at some point? And I think that U.S. is grappling with that as a whole. Thank you all very much.
Thank you, Jeb. We have another question.
I have a question and a kind of question statement. First question is, okay, you're pre-oping your patient and they're on Ativan.
Okay.
Do we have any obligation to intervene and say, whoa, danger, you're over 70, you probably don't. Well, when the alcoholic that takes a benzodiazepine instead of being a raging drunk does that until they live, till 80, they're still a raging drunk, they're just a quiet raging drunk.
Right.
Okay. So what do you say about the lorazepam if you see it on somebody's thing? Do you call attention or you just go,
So I have so Michelle said depends, and I have a geriatric high-risk surgical program, and we meet as an interdisciplinary group every Wednesday morning at 6:30. And what we tell patients when they're taking meds that are bad for their brain is we ask them whether they feel like they can cut down. We find out how long they've been taking it, and sometimes it's on their chart and they don't actually really take it. Other times they really do take it, sometimes even more. But whether it's marijuana, alcohol, sleep meds of all kinds, sometimes we'll suggest other alternatives for sleep meds, and we'll try to enroll them in seeing how much they can consider decreasing if they possibly can. We tell them our concern, and we see what they can do.
Interesting you should say marijuana, because I'll see a lot of patients my age, and they're like, yeah. And I'm like, wow, okay, whatever. So my next question was, anybody remember Jack LaLanne? Okay, muscle man, incredible guy. Swam across from somewhere to such and such whenever he was so old, and then he just disappeared. And that's because he eventually died, I think of pneumonia. And it looks like people tend to just kind of give up or get away from that caring, that over, caring where they're working out every day. So, do you agree?
There's an investigator named Tom Gill who works at Yale, and he's done an amazing study called the Precipitating Events Project, the PEP study, and it's 700 patients plus who are all part of an HMO health plan, and what he did is my favorite study ever. He just called everybody every month and asked, "How are you doing?" He did a simple ADL check, and he got to the point where they got like over 98% follow-up, and they were able to follow the whole group until they all died. And he has published papers in the New England Journal and other places that show the trajectory of function before death. And there are all different trajectories people take, but there are certain types of trajectories. So I highly recommend his work if you haven't seen it. It's actually just Tom Gill, Gill, and it's inspiring work from a researcher's perspective, but it's for people interested in geriatrics. It's really a great resource.
Mick Jagger, there's another one.
No, he's still going.
And Hans Stabenow also.
Yep. I'd also say that in terms of downward trajectories, falls are a really big component.
Well, if there are no other questions, this was a wonderful panel and a great discussion. I want to thank you all for being here late in the afternoon. I hope you had a great meeting, and safe travels for those of you heading home soon. So thanks again.